I hope the questions were appropriately stumped you, but we're gonna get to it. And before we get started, I think there was a question from a couple people for Luis and Miriam. Did these questions come from one of the MKSAP's editions? And which one was it?
Great question. Yes, it came from the MKSAP from last year, I believe. So
Okay.
18, I want to say.
From 18, cool.
And I might have modified mine a little bit, just FYI, so they won't be exactly the same.
Yeah, they're close, but not exactly.
Cool, sounds good. And then just FYI, Miriam, if you drag another window in front of the on top of the box to pop up. Cool. Alrighty, take it away.
Okay, well, I guess I'll start talking. Good morning, everyone. I feel like 100 years old because I have so many screens in front of me, so I'm still not exactly sure what you're seeing and what I'm seeing of the 19 Zoom windows that are open right now. Tree, how's it looking? How's it so far?
It looks perfect. I see MKSAP board review, infectious diseases.
Amazing. So just for quick introductions, and maybe Luis, I can help be your assistant and advance your slides for you when you go.
Sure.
I'm Miriam Schwarz. I'm a hospitalist at the VA. I think I know most of you. I did this internal medicine residency program 100 years ago. And yeah, I do a mix of kind of day and night inpatient medicine at the VA.
Great. And I'm Luis Tulloch. I'm one of the infectious disease doctors over at the Seattle VA. And I did my residency just a little bit before Miriam. And then I've been at the VA for, 10 years total now. There was a little break in between there for fellowship, but I'm back.
Amazing. Okay. So we're going to jump right in because obviously we've got a bunch of questions to get through. So just right off the bat to let you know that we have no financial disclosures. I'm going to actually stop sharing for just a second and fix one setting here.
I can share too if you want, Miriam, if that works.
Oh, no, that's all right. So thank you so much.
In the meantime, I look into people's houses here. Very nice. Just via Zoom.
Actually, okay, I'll let you share, Luis. That's fine. There's so many screens here.
Yeah, no worries. We'll do this. Let's see. And I will be sharing this one. And we will do this thing. And we will flip that. Actually. Let's see, what are you guys seeing? You guys are probably seeing my first screen, right?
Seeing your presenter view right now. Just seeing the notes and the...
And I can change it. So swap. So you guys should be seeing
perfect
this. All right, perfect.
Yeah.
All right, great. So sort of the intros. So we have a few learning objectives, and it's the main one is to diagnose and treat common infections, to recognize the current knowledge gaps in the management of these infections, and 3, just understand common mechanisms of antibacterial resistance. And I will move this out of the way here. Great. All right, so question 1. So I should ask, it was about diabetic foot ulcers. What did people answer? I'm just kind of curious what the predominant answer was. People can throw it in the chat. And I will figure out a way to look at the chat. Let's see. Perfect. A, bone biopsy. A. 2 up hashes. That's all right. That's good. All right. Perfect. So great. That's fantastic. That's the correct answer. So yeah, so this is a good, I like to, in practice, I like to separate diabetic foot ulcers into 4 buckets based on the severity of infection into, uninfected, mildly infected, moderately infected, and then severe sepsis and NSTI. And the difference between, these last 2 here is that this is usually 1 or 2 systemic symptoms, but not meeting criteria for severe sepsis yet. And, the organisms that are in the ulcer don't really change. What changes is how much you care about covering them. So for, milder infections, you only cover the very most likely things, Staph aureus, strep, Enterobacterialis or Enterobacteriaceae, and anaerobes. And then when you have something very severe, then you start wanting to cover Pseudomonas, Pheromonas, Clostridium, Vibrio, things of that sort. And then every time I see someone with a diabetic foot ulcer, I always ask myself, what's the patient's glycemic control? Is it optimal? What's the vascular supply to the affected area? And then the question always comes up of osteomyelitis. So if you have someone with an infection, that's something I always ask. If they have an uninfected ulcer, but it's taking a little bit too long to heal, then I ask that question as well. And in general, like the question alluded to, if the ulcer is not infected, you don't do antibiotics, and you can definitely ask this question. And there's a few ways of, there's a few clues to see if the patient has osteomyelitis. And yeah, I would love, and I think we only have an hour, so I won't ask too many questions of the group, but feel free to ask me questions as we go. I have my chat box open here. So there's this great review article that I still refer to from 2008. And it looks at, different symptoms or signs that may clue you into the presence of osteomyelitis in patients with a diabetic foot ulcer. And things like ulcer size, probing to bone, visible bone, have high specificity, but are usually fairly insensitive. An ESR over 70 is good, but it's really hard to interpret when you're dealing with an acute soft tissue infection or systemic infection. X-rays, typically fairly specific in practice, but they won't catch early osteomyelitis. It usually takes 21 to 28 days for you to see any changes on X-ray. And then MRIs are most sensitive modality for diagnosing osteomyelitis, and it can definitely identify it early. But you have to, or not you, but the radiologist has to be very good at differentiating between osteomyelitis, reactive edema, and Charcot changes. And I won't belabor this table, but essentially this is a nice way to refer to it, to look at the different changes from a radiologic perspective. I will point out a couple of quick things about MRIs and distinguishing between osteo and reactive edema. So if you look at an MRI, a musculoskeletal MRI, your T1 weighted images are going to look at the bone marrow and the bone. And basically in osteomyelitis, you're going to see a decrease in intensity, which kind of signifies bone destruction and replacement of the bone marrow with fat. And in reactive edema, you won't see that. And in both cases, you'll see an increase in intensity in T2. And basically T2 just tells you that there's inflammation in an area. It's kind of a fluid sensitive sequence. So in this example, the dashed line tells you that there's reactive edema. So you see that in T2, there's some brightness, but there's no, right here, but there's no decrease in intensity for T1. And then in this solid line in T2, you see brightness again. So this is brighter compared to here. And then if you look at T1, you see kind of this decrease, this loss of intensity compared to the other bone. So this one's osteomyelitis. Now, the question always comes up about whether or not superficial cultures help for diabetic foot osteo. So to answer that question, you kind of have to go back to what is the goal of a culture, right? So the goal of a culture is to identify the organisms responsible for the pathologic changes in the affected tissues, and also to obtain susceptibilities to optimize antimicrobial therapy. So again, big table, you can refer to it later, but essentially this is a bunch of studies comparing concordance between superficial cultures with deep cultures. And in general, you see that the concordance is really low, and superficial cultures tend to catch additional bacteria that may or may not be pathogenic. And then the other point is that if you're going to trust it for any reason, it would just be for Staph aureus. That's what has the highest concordance. And just a couple of slides on the treatment of osteomyelitis. So this is an area of ongoing debate, and it has been ongoing since the late 1800s, actually. So essentially, it's very difficult to study diabetic foot osteo. And we have a lot of standard of care practices in place which make it difficult to randomize patients. But essentially, medical treatment, which is antibiotic treatment, and surgical treatment, which is amputation, have pretty much the same outcomes. So the one thing that we know is that we used to in the 70s, 80s, 90s, we used to give people 12 weeks of antibiotics, but over time we have been finding that that's not really necessary. So the standard now is to give 6 weeks, and you have the same outcomes with less antibiotic adverse effects. And there's currently a randomized controlled trial going on looking at whether or not we can do 3 weeks in select patients that have had appropriate debridement. So that's my osteomyelitis, but any questions about that?
One question about the time at which you decide to switch from an oral agent to an IV agent.
Yeah.
Given the data that came from the Oviva trial, basically saying like, if you have perfect adherence, to either regimen, that there's, no difference, maybe even a little bit of superiority for the oral regimens. I noticed like when you said like, oh, there's like moderate infection of the ulcer, you're going ahead and switching those patients to IV. What underlies that choice?
Yeah, so that's all empiric regimen, right? This is when you see the patient for the first time and you don't really know what bacteria are there, then you're going to
So confident. Okay, here we are at question number 2. So the educational objective of this question, I think hopefully pretty fairly obviously to you guys, was to treat a severe C. diff infection. Luis, you look puzzled. Is my screen showing up the way I totally intended to show?
Yeah, no, it's great. Thanks.
Yeah,
no, it's good. It's perfect.
Beautiful. So yeah, the kind of the point that MKSAP brought up was from the choices that they gave you, basically The question was about a woman with an initial episode of severe infection, severe by both ACG and IDSA criteria, because she had elevated white counts, a low albumin, and an elevated creatinine. So of the choices that they gave you, probably you chose this oral vancomycin as the best one, but there was nowhere mentioned in the question about fidaxomicin. So just wanted to briefly see if any of you guys had thoughts or questions about fidaxomicin, because that's actually what I wanted to spend just a couple minutes talking about. I'm going to pick on people with cameras on. Felicia, Christian, Lauren, Sarah, Ruth, any thoughts? Did you think about fidaxomicin at all?
No, we just looked at the answer choices.
Solid. I love it owning the honesty, but also that's clever test taking, Sarah. You chose the best option offered to you, and guidelines are changing all the time. So it sounds like at the beginning, there was a question about what version of MKSAP are we working from, like what edition? And yeah, this was a kind of more recent update in terms of C. diff treatment recommendations. So just wanted to spend 1 or 2 minutes talking about fidaxomicin. So, and quick shout out to Jenny Ryu, who's a colleague of mine and Luisa's at the VA. She did an awesome journal club for us about a recent IDSA update for the guidelines of treatment of C. diff infections. And so I borrowed heavily from her slides for this. So fidaxomicin, brand name Difficid, is a macrocyclic just like vancomycin, daptomycin, macrolides like azithro and erythro. Similar to vancomycin, kind of the treatment principle is that fidax is minimally systemically absorbed. So you're going for that same delivery, that high concentration in the large intestine. So there's beautiful looking fidaxomicin, just so you can really burn the molecular structure into your brain. As far as kind of comparing and contrasting between the two of them, big things I want you to take away from this slide. The cost, honestly, is one of them, because we're going to talk a little bit about the resource limitation of fidax versus vanco, and certainly the availability. So during our residency program, our whole world is kind of, what do we do at the VA versus hard to do versus UW? But certainly there's a lot of other practice settings where we'll be working where fidaxomicin won't necessarily be widely available. And then, yeah, the bactericidal versus bacteriostatic aspect of it. Just for those of us, in terms of like a little context, you know, when Luis and I were in training, vancomycin was, I think, more recently shown to be superior for treatment outcomes than metronidazole, but metronidazole was still an acceptable alternative for treating C. diff. Fidaxomicin was approved for treatment in 2011. There was a New England Journal published phase 3 trial comparing fidax and vanc outcomes. So why did it take then 10 years for now this treatment algorithm to change? And why then, yeah, would this MKSAP question maybe be a little more outdated than recent guidelines? There's a big meta-analysis. That's what the IDSA recommendations were based on, the original New England Journal trial and a few others, looking at both non-inferiority and superiority outcomes with fidaxomicin. And really, like, the take home that I want you to remember about fidaxomicin, this is just showing the 2021 update, is that the reason we like it is because it tends to reduce your risk of recurrence. So the official guideline is that for patients with an initial episode of C. diff infection, the IDSA suggests fidax rather than a standard course of vanc as of 2021, placing a high value on the beneficial effects and the safety profile, but obviously the implementation depends on available resources. So vanc remains an acceptable alternative. So take home, initial episode, consider fidax. In terms of criteria for use or when you should especially think about it, or if your patient has these increased risk factors for recurrence, some of them listed here that you can see, and or if the patient is already having a recurrent episode. I'm just finally putting in a plug for Consulting ID if you're running into multiple recurrences. And bezlotoxumab will be something that I'm sure will be on your boards 5 years from now. But again, it's sort of a practice update in recent years, thinking about co-administration of bezlotoxumab for reducing recurrences. One last kind of final review about this question. So in terms of why the other answers were wrong. So answer A, we don't do fecal microbiota transplants routinely, not recommended for an initial episode of C. diff infection. And for fulminant C. diff infection, the IDSA recommendations really haven't changed to do PO and PFT vanc as well as IV flagyl or metronidazole, and the PR vancomycin if ileus is present. I'm going to stop sharing my screen for a sec, Luis, and then in terms of questions, what I miss, guys? Ruth loves FIDAX. It's so beautiful. Lauren also loves FIDAX. And yes, Ruth brought up at the VA, we've been denied a request for FIDAX. You're exactly right. This is a resource limitation issue. So we have these criteria for use where you need to have clinical C. diff infection plus one of those other risk factors for recurrence, like the age, immunosuppression, or episode of recurrence already. So it's still sort of restricted in its use. And Luis was reminding also that review in the VA, it's still restricted as well for recurrences.
And I'll say that we actually recently de-restricted fidaxomicin as first-line therapy for a first occurrence in patients who are over 65, immunosuppressed, have IBD, or are on concurrent systemic antibiotics. The issue is that since we're moving to Cerner, they haven't been, the IT folks are not doing our order sets at this point. So if you run into that at the VA, call either the stewardship pharmacist or ID, and we'll help you get it if the patient is appropriate for it for a first-time event. Sorry, Miriam, I just wanted to address that. Yeah.
Oh, thank you so much. That's why I'm so glad to have you here. It's already almost 10, so we're going to keep moving forward. And Luis has got the next couple questions. Luis, you're on mute, bud. And we are seeing your screen of the educational executive for question number 2, treat severe CDI. You want me to do it? I'm happy to. Finally got it down.
Sorry, I couldn't find where my mute button was. So yeah, all right. So anyways, so my question here was, this was about syphilis serology. So again, I was curious to see what people answered. Can people hear me now?
Mm-hmm.
Great.
Yeah.
Yeah, so what did people pick for this question? No treatment. Excellent. Fantastic. All right. I like it. Yeah, so that was the correct answer. And we'll go over kind of the clinical stages of syphilis. They always confuse me and some of that diagnostics for it. Great. Yeah. So essentially, again, this is a chart that you can review on your own, but this goes over the different stages of syphilis. So first you have infection followed by primary syphilis within the first 90 days. And this is usually your painless chancre, which is an ulcer at the site of inoculation. And it's often followed or accompanied by some regional lymphadenopathy, so usually inguinal lymphadenopathy. Then you have your secondary syphilis that for a few more weeks, and that's your classic great imitator phase where you have the rash, you have these kind of mucus patches in the mouth, and then you have these condylomata lata in kind of mucosal areas as well. And then after several months to a couple of years, you get into this latent phase where you have positive serologies, but no clinical signs of infection. And if left untreated, after many years, I'm talking 5 to 15 to 25 years, you get tertiary syphilis, which essentially has two different presentations, aortitis and gummatous syphilis, which are essentially kind of tumors. And this slide just reminds you that CNS involvement can occur at any time in the course of syphilis. And then that gets us to diagnosis, right? So I like to use that clinical stage framework to look into diagnosis and then treatment. So you have, two general methods for diagnostics: direct visualization or direct detection, and I'll go over that. And that's usually best early on from primary syphilis to early latent syphilis. And then you have serologies, which come in two flavors: treponemal serologies, which will be positive for life, and then non-treponemal serologies, which come and go with disease activity. So syphilis direct detection, there's several different methods: dark field microscopy, silver and immunohistochemical staining, and PCR. It requires a lot of spirochetes to be present for you to actually see them. And you usually get those spirochetes from chancres and those moist lesions of secondary syphilis. It's no longer widely used in clinical settings. And in syphilis serologies is the preferred method for diagnosis. They come in two flavors, like I said: non-treponemal, which is your RPR, and VBRL. The targets are antibodies to cardiolipin that's released by damaged host cells. And the titers, like I said, decreased after treatment. And you can get a bunch of biologic false positive from other systemic infections and lupus. And then you can get false negatives as well. So actually, about a third of folks with primary and tertiary syphilis have a negative or kind of burnt out RPR. And then treponemal antibodies are your FTA-ABS, TPPA, and EIA. And these are essentially the targets for these are IgM and IgG to treponemal antigens, and this remains positive for life. A quick word on the different serologic algorithms. So, we use the serologies in conjunction with each other. So in high prevalence settings, you use this classic algorithm in which you use the non-treponemal, the RPR first, and then you follow it with a treponemal antibody after. The UW system and other low prevalence settings use this reverse sequence algorithm, in which you use a treponemal test followed by a non-treponemal test. And if you get discordant results, you do a different treponemal test. Sorry, I'm just reading the chat. That's pretty funny. And a quick word on treatment. So the preferred treatment for syphilis, the answer is always going to be penicillin. And the type of penicillin is going to vary depending on whether or not you have CNS involvement. So for CNS involvement, you want IV aqueous penicillin G. And for everything else, you're going to do benzathine penicillin G, which is a depot long-acting form of penicillin. And again, another quick slide for reference. The number of doses you're going to give of the IM penicillin will vary depending on whether you have early or late syphilis. And that's all I have. yeah, let me know if you have any questions for that. If not, I'll move on to the next question.
Luis, did you see Hillary's question in the chat that she heard a rumor about RPR false positives in the setting of COVID vaccination? Is this real?
Ooh, that is, I had not heard of that rumor, but I will definitely look into it. I'm not sure. But I mean, if it's an inflammatory state, I can kind of see that happening. But I don't know the answer off the top of my head.
I think our groups, oh, sorry, go ahead.
Oh, Lauren, go ahead.
I was just gonna say, I think one question our group was talking about was, and you kind of went over it, sorry if I missed the answer, but since RPRs can be falsely negative, when you have such a high risk patient, how do you trust the RPR?
Yeah, that's a fantastic question, right? So the question that comes up a lot at the VA is, I have this patient with kind of some memory, cognitive issues. I got an RPR that's negative, but his syphilis EIA is positive, right? And basically you base that on history. So you kind of have to do some digging to see if the patient ever had syphilis and get the RPRs. You can get that from most counties. For us, we call Harborview, and they have a good database of that, and we can get a good RPR history. If they had a good, if they had documented RPRs and were treated for syphilis, and you saw a reduction in the RPR and like no other risk factors, like no, increased risk from sexual activity, then you can say, okay, this is old syphilis, it was treated. But if you don't have that, then you're kind of forced into like a shared decision-making conversation with the patient of whether or not to treat them for, and if it's just tertiary syphilis, that's easy. You just give them 3 doses of IM penicillin a week apart. But when they have possible CNS involvement, that's a bit trickier, and you often kind of have to decide of whether or not to treat them empirically for CNS infection with IV penicillin. Does that answer your question, Lauren?
Yeah.
Great. Excellent. All right, so question 4. Oh, I like this one. So, I do stewardship, so a lot of we like a lot of our resistance mechanisms. So again, I'll ask, what did people choose for this one? C and D. Perfect. That's a conversation I like to hear. Excellent. Great. So resistance mechanisms, right? So there's 8 different mechanisms of resistance that we know so far. You have decreased permeability, so basically a thicker wall, a positive charge, loss of porins, what have you. Antibiotic binding, where some molecule binds up the antibiotic. Antibiotic inactivation, which are beta-lactamases. Essentially, some molecule destroys the antibiotic or inactivates it somehow. Then you have changes to the target. So you can protect the target, you can alter the target, you can make a lot of the target, and finally you can get rid of the target of the antibiotic via an efflux pump. There's an 8th method that I haven't pictured here, but essentially you can bypass whatever the target was doing. So find an alternate way of doing your metabolic activity. And again, this chart, also for reference, is for the different types of beta-lactamase harboring organisms that you'll encounter in practice. And you basically have 3 big buckets. You have MC organisms, extended spectrum beta-lactamase organisms, and carbapenem resistance Enterobacteriaceae or Enterobacterales. And the big thing here is that in terms of you can distinguish them by their susceptibility pattern in vitro. So ESBL, your clue that's present is going to be resistance to ceftriaxone. If you have a bacteria that's resistant to that, you're going to think ESBL. And what distinguishes it from AMP-C is that it's susceptible to cefamycins, which are antibiotics that we don't really use that much, but they're like cefotetin, cefoxitin. And they're also susceptible to beta-lactamase inhibitor combinations, so like pip/tazo. Usually you see some susceptibility there. Yeah. And then let me make sure I don't have anything else to say about this. That's right. Yeah. And then, you know, the difference between AMP-C and ESBL compared to CRE is that, as the name implies, CRE are going to be pretty resistant to everything, including, you know, pip/tazo, cefepime, and the carbapenems. So how do you treat these? Fortunately, back in November of last year, the IDSA released some guidelines on how to do this. And essentially, you have to think of what type of infection you're treating. And also the phenotype of your isolate. So cystitis due to ESBL organisms can be treated with you know, things like nitrofurantoin or TMP-SMX. And if you don't have those available because of resistance, then you use carbapenems and other alternate agents. Yeah, sorry, I just yeah, Miriam's comment. Great. Yeah, they do look sus. Yeah, for and then for every other infection, for more invasive infections, you're going to reach for carbapenems or antibiotics that have high concentrations in tissues like fluoroquinolones and TMP-SMX again. Sometimes the question comes up, I'm sure you guys have encountered this. You have an organism that's resistant to ceftriaxone, which implies an ESBL, but then you see that it's susceptible to cefepime and or pip/tazo. So the question always comes up, if it's susceptible, can we just use those? And you know, the answer, according to a couple of randomized controlled trials, is not if you're treating a bloodstream or another invasive infection. So here on the left, you have a small trial looking at patients that had this phenotype, and they were given cefepime. And essentially, they had to stop recruitment into the cefepime group because they saw kind of a big difference in mortality and clinical and microbiologic success. And then on the right, you have this slightly more famous trial, the Merino trial, which essentially looked at whether or not at the 30-day mortality in patients that received pip/tazo compared to a carbapenem, meropenem in this case. And what they found was that pip/tazo was not inferior, meaning that you should use a carbapenem. And then these, given the time, I'm just going to quickly just mention that for AMP-C, it's actually, I really like AMP-C because what you'll see in practice is you'll see that they're sensitive to ceftriaxone, but you shouldn't use that. But how do you know if it's sensitive, right? So the way you know is by recognizing the bacteria that are likely to harbor AMP-C beta-lactamase. So these are Citrobacter, Enterobacter, and Klebsiella. And again, for things like cystitis, you can use ceftriaxone if the patient's improving and the organism's acceptable. For more invasive infections, you should use either carbapenems or a cefepime type antibiotic, or cefepime. And then for CRE, I will say that if you encounter CRE, if ID or stewardship has not reached out to you, you should probably just reach out to them. And I doubt that you'll be asked questions about this on the boards. Great. All right, I'll give you the floor, Miriam. Unless there's questions about this. Oh, the
yeah,
answer. So the answer is ertapenem. And the reason for that is because both will cover it, but meropenem has additional pseudomonal coverage that you don't really need in this case because you're not dealing with pseudomonas.
This might be a really dumb question, but from the question stem, could we figure out if this was an AMP-C organism? I was trying to.
Oh, yeah, no, that's a good question. Yeah, I think the clues that they gave you, and let me pull up the.
It was.
Yeah, so.
Yeah, go ahead.
Oh, no, so I think, yeah, so basically they gave you susceptibility to piptazo and susceptibility to cefepime. So the susceptibility to piptazo might have clued you in that this was an ESBL as opposed to an MC. But that's the only clue, and in practice that may vary.
Can they be both or
yeah,
no?
Yeah, no, that's an excellent point. So one bug can have multiple ESBL enzymes, and in addition to that, they can have pumps and they can have different things that will increase their resistance. So it's often difficult to know. Yeah. Does micro test for MC? Sorry, go ahead.
Oh, I was going to say there's one more question for you.
Does micro test? So testing for MC can be done. It basically requires you to combine to test for susceptibility or resistance to a combination of a cefamycin with a beta-lactamase inhibitor. So a lot of micro labs don't do that. We don't do that at the VA, but you can do that at other places. Yep. So it sounds like Harborview does it. So yes. And actually, the other thing is that they'll probably also look, what we do at the VA is that we look at the bug and our stewardship team will actually call you about it if it's an invasive infection and tell you that you should probably use something else. All right. Great questions.
Cool. Really good questions. Thank you guys so much for participating. Andrew dropping a Glockenflecken video in the chat. Essential viewing. Okay, fantastic. I'm not even kidding about that. Okay, moving on. So here is question number 5. You'll remember it was about a 46-year-old woman with a PICC line that was tender and erythematous, and she had 2 sets of positive peripheral blood cultures, growing coag-negative staph. So the educational objective of this question, fairly straightforward, is how to treat coag-negative staph CLAB disease. Before I jump in with some teaching points, any questions, thoughts, concerns about the answers you were given right off the bat? Lauren, I know you had thoughts. I would be shocked. Talisha, I know you have thoughts. Okay, I won't put you on the spot too much, but the questions basically gave you choices between extended course of Vanco with keeping the PICC line in. Also keep the PICC line in, do a TEE, just take the PICC line out, or take the PICC line out and do cultures. So sort of similar to what we were talking about with Sarah in my first question, you're sort of choosing from the best of these answers, but probably not the best of all possible answers, or really even what is IDSA recommended. So the MKSAP key point here is that Cons is less virulent than Staph aureus and less likely to be metastatic, and may be treated with simple removal of the catheter. We're going to plow forward and talk about how that's probably not your most preferred answer, but yeah, taking out the catheter sounds like a great idea. So in terms of central line associated bloodstream infections, just a quick reminder that you're at risk from any intravascular device, but there are some kinds that carry more risk of bloodstream infection than others. So non-tunnel, so the more kind of superficial central venous catheters carry more risk. So this lady's PICC, one of the riskier ones. These are some of the most common pathogens that you're going to encounter. So I think MKSAP probably chose coag-negative staph as really one that you're going to see so frequently. Oh, sorry, I haven't put that slide up yet. In terms of different kinds of coag-negative staph that we're talking about, I threw up some examples. I wanted to mention Staph lugdunensis in particular. because of the infection profile that's similar to MSSA or MRSA. So staph luxdensis, even though it's, just a coag negative staph, can cause endocarditis, bone and joint infections, SSTIs, and so forth. Obviously, your coag negative staph, these are frequent skin contaminant or contaminant from skin flora, but still can cause these nasty infections. And the stem mentioned that the cause was resistant to methicillin. I don't think they were trying to trip you up as much as just to say that coag negative staph are frequently resistant to methicillin. You're going to start out with IV zinc as your empiric therapy. And usually the call you're going to get from the lab is that your patient has GPCs and clusters, just like this lady. So you're going to just start off with zinc and end up treating a lot of good stuff. So here is what I'm saying about different common pathogens, coag negative staph being number 1, and Staph aureus being number 2. And here's a bunch of others along with that. Some of the most common ones you're going to see. So catheter removal, and that's kind of the major crux of the right answer for this question. So while, yes, there are ways that you can salvage the catheter, and we'll talk about that on the next screen. Bottom line, if you can remove the catheter, just remove it. If it's not needed anymore, or you can make do or find an alternative, just remove it. These are some of the slam dunk, let's not negotiate about leaving it in. We got to get that catheter out. Clinical criteria. So if you're having metastatic sequelae of infection like suprative thrombophlebitis or endocarditis, if you tried to leave the catheter in, but the bacterium is persistent or the patient is clinically decompensating, those are kind of, you can call ID certainly, but they're going to tell you to try to get that catheter out. In terms of microbiologic factors for what would prompt you to get that catheter out as soon as possible, these are some of the organisms that should make you think, let me get this catheter out, instead of finding ways to treat through or around it. So the simplest answer, and the one that MKSAP is looking for here, is to remove the catheter, but also that you've got to repeat those blood cultures after the catheter is out to document clearance. And day 1 of your treatment course is going to end up being your first day of negative blood cultures. So the MKSAP answer doesn't say anything about antibiotics at all. It just says take the PICC line out and repeat blood cultures. But what about antibiotics? And yeah, what about catheter salvage? Isn't that a thing? So in terms of antibiotic therapy, the thing Luis and I want you to remember is really that all CLABSIs need antibiotic therapy. That just make it as simple as that in your mind. Yes, there are some very specific circumstances where maybe you can get by without it, but in terms of IDSA recommendations, what you're going to hear from almost every ID attending is just you're going to need some antibiotics as well, even if it's just for a couple of days. If you're going to salvage the catheter, meaning leave it in place, and that might be appropriate in some kinds of situations, uncomplicated CLABSIs or certain populations where the risk of pulling out the catheter is more than the risk of leaving it in place, that may be possible, and you can do something called lock therapy, where you're giving high doses of antibiotic into the catheter itself to try to sterilize the catheter. I would just say, if you're going to try to do catheter salvage and leave the catheter in place, or even if you want the discussion about risks and benefits and how to kind of weigh that out, that's a great time to maybe consult ID. And in terms of IDSA guidelines, the last ones on CLABSIs actually were from 2009, so they're quite old and actually in the process of being updated. So just wrapping up this question, other kind of wrong answers that they had, you shouldn't need a 4-week course of vancomycin as far as we know yet in this question. This patient doesn't have hardware, hasn't had any problems with clearance yet as far as we know, and it's a cons CLABSI, so unlikely even if you were going to salvage the catheter. And TEE, same thing. You'd mostly do if there were a murmur, evidence of metastatic infection, or persistent bacteremia, but not necessarily initially. We'll pause there. Any questions about this question? perfect. The crickets also understand exactly what's going on in the question. So we're gonna dovetail right into another question that kind of builds off what we just learned about CLABSIs. And this was about managing candidemia, so a different kind of CLABSI or a specific kind of CLABSI, and managing with empiric therapy. So I'm going to guess, looking at the answer options, where basically C, D, and E were like wait and do nothing for now, versus A and B were do something now. I'm going to guess that you guys weren't tempted by C, D, and E. Anyone have any ideas about the difference between A and B? So this was begin empiric therapy with MICA versus begin empiric therapy with Fluke.
Our conversation just kind of came down to the acuity of the clinical situation, and like you don't have the time to be wrong with the fluconazole. So just go ahead and start with the micafungin because he is so sick.
I think that's a beautiful answer, Ruth, and thank you for putting it that way. But yeah, in general with candidemia or fungemia, you really don't want to mess around. And I like how Ruth said that you just don't have time to be wrong. So you're not treating it as a contaminant, and you want to start a little, in this case, broader. And Nick also says MICA is broader than Fluke. So we'll talk about that echinocandins candins are more appropriate as empiric therapy because, yes, there are a lot of resistant strains of Candida species. So that's really the point of this question. So a couple minutes on fungemias. So aside from even how sick the patient is, even if your patient doesn't seem that sick, candidemia is an incredible virulent clinical syndrome with 30 to 50% mortality. So really clinically significant. Number 4 cause of CLABSI, so certainly relevant to your clinical practice in the hospital. And in terms of epi, Candida albicans is most common, but I wanted to mention Candida auris as a emerging potentially MDR species of Candida. So take home here, yes, is that don't sleep on a positive blood culture that's showing yeast or fungi. Never treat it as a contaminant, and always start your empiric therapy immediately. Your mortality is going to be linked to the timing of your onset of therapy and your source control. As far as candidiasis, we're talking about a spectrum of disease here, right? You can have superficial mucosal infections going all the way to invasive disease, metastatic organ infection. So anything from thrush to meningitis, chorioretinitis, severe sepsis. And really the challenge is that it's delayed diagnosis because it's slow to grow, and that your patient won't necessarily have specific signs and symptoms. So when you're thinking about your candidiasis and whether it could be invasive, keep in mind some of your risk factors, certainly your neutropenic patients, your patients with active malignancies, also patients who have been on broad-spectrum antibiotics for a while, and on the surgical wards, you're going to see this a lot in your abdominal surgery patients. But so being mindful of, are they already at increased risk? TPN and PPN probably one you guys know about too. And then having a high level of clinical suspicion and concern. In this patient, this was just a singular fever that prompted this workup. And I'm just gonna, as far as like the take-home management of candidemia CLABSI that I want you to remember. So empiric therapy with an echinocandin like MICA or TAFO as soon as possible. Take that catheter out. This is one of those microbiologic, don't screw around, don't leave the catheter in. That catheter's got to come out as soon as it's safely possible. And again, if there's any risk in like your neutropenic patients who are at high risk of bleeding, that's a big conversation, and ask ID for help for that conversation. Repeat those blood cultures as soon as the catheter is out to document clearance. Consult ID for help. Opto exam within 1 week, and these are all the bolded ones are IDSA recommendations I want you to remember. Opto exam is standard part of management of candidemia. You can have chorioretinitis, But you need to do it when the patient is not neutropenic. So it's within 1 week or within 1 week of count recovery for a neutropenic patient. And then finally, you're going to need to treat for at least 2 weeks from clearance, but it may be longer depending on complications, and you can de-escalate to an azole when you have your sensitivity data. So that was fast. Hope you understood most of that. Had questions? Any questions before? I think we're about at time, so we want to make sure you guys have questions before we wrap things up. Even if it's questions about the last 2 questions that we're not really going to have time to go through the slides for. And Luis has made you some beautiful slides in the PowerPoint for you to learn from when you guys get to look through this on your own time. Did you guys learn things today? Felicia says yes. Sarah says yes. Sarah says the best. Thank you. Thanks, Kevin. Good to know. Oh, yeah. Luis is putting some answers in the chat about question 7, where the educational objective is going to be a little bit about MICs when you're using vancomycin to treat. And question number 8, which is going to be your framework for mild non-purulent infections, right? Purulent versus non-purulent infections. Yeah, Luis's slides are baller. I agree, Nick. I love that chart. Yeah,
Great.
Luis, anything to say?
Nah, great. Thanks for having us, and yeah, enjoy the rest of your academic half day.
Awesome. Yeah, thanks, Luis and Miriam.